to just start making his way up here. So let's just check in. How's everybody doing so far? Great. Yes? You're happy and fed and learning a lot. I'm sure it's a lot to take in, but you're here. Let's get it going. So who went downstairs for exercise class with a packed house, right? And who did dance for PD? What'd you think? It was good. Yes, you know that we are starting Dance for PD here with RVNA Health starting at the end of February. So this is an opportunity, and it's free because the APDA, thank you, Marlene, and the Connecticut chapter has given us a grant to support Dance for PD for free for you. So please try it out because it'll be an amazing thing. Who went upstairs to hear Dr. Tanaz? That was a packed house too. Learn something new? Good. Exercise, my favorite topic, right? And who listened to Dr. Chan in the family consult room? Thumbs up? Yeah? It was good? Awesome. Well, we're only halfway through. So we make sure you're settled. I just want to mention, we are RVNA Health and we are the Parkinson Center, but we are a nonprofit. This was a great opportunity. Thank you for coming. Thank you for our sponsors. Otherwise, we couldn't have it. But if you feel so compelled to help support our cause, our mission, our center, there is a QR code on the back of your agenda, against back of your program, so that you can help us continue supporting these amazing programs. And so let me introduce Dr. Meytin. Thank you.
All right, can everybody hear me?
Yeah.
Okay. So for those of you who don't know me, my name is Dr. Leon Meytin. I am one of the movement disorder neurologists. I know a lot of family faces here. I'm one of the movement disorder neurologists for Hartford Healthcare's Chase Family Movement Disorders Center. My office is located in Bridgeport, but we have locations all across the state. So my task today, which is a very tall task, and I only have a short while to do it, is to talk about some of the advances in research. A few of these drugs are already available, many of which are still being researched in early to mid to late phase trials. So I'm going to highlight some more than others just based on time, because it could take me 3 or 4 and 5 days to get through all of the drugs that we have available. So I have no financial disclosures. So I'm going to briefly just talk about a little bit about Parkinson's, although I'm sure many of you are aware of it. And I'm going to talk briefly about how we currently treat Parkinson's, and then really how we're moving to treat Parkinson's over the next 3, 5, 10 years, hopefully. So the way that we currently treat Parkinson's for the most part is based on dopamine. So we have a lot of drugs available on the market. And for the most part, most of them in one way or another boost dopamine. The most common one being levodopa, which has been around now since the 1950s. There's a lot of other agents that either act like dopamine or target dopamine receptors or boost the availability of the dopamine that you have currently available. But it's something related to dopamine. That's really been the treatment that we've used for the last several decades. But that's slowly starting to shift. So, dopamine therapies really are symptomatic therapy. All we're really doing is putting a Band-Aid on the symptoms. One of the hallmark features of Parkinson's is that your brain doesn't produce sufficient levels of dopamine. And so we just find a lot of ways of getting it back to you. However, the better way of treating it, hopefully the way that we're moving to in the future, is modifying the disease process, either slowing it down, reversing it, or changing it altogether, more than just symptomatically treating it. So this is actually an old slide, because there's many more trials available now, but there are hundreds and hundreds of clinical trials actively going on in the country and in the world right now. So one of the kind of biggest classes of medications that we're looking for, and one of the things that you're going to hear a lot about over the next few years are these alpha-synuclein agents. So alpha-synuclein is a protein. It's a perfectly normal protein that's found in various parts of your body. But one of the things that happens in Parkinson's is the protein gets misfolded and starts clumping up. And when it clumps up, it basically produces a traffic jam in your brain. And so we know that that is one of the hallmark features of Parkinson's. So what if we go ahead and attack these abnormal proteins? And that's exactly what a lot of research is focused on nowadays. One way or another is targeting alpha-synuclein. The two biggest ways of doing that right now, one is through antibodies, and the other is through vaccines. So similar to the vaccines that you get for flu or for COVID, really what vaccines do is they attempt to elicit an immune response or some kind of response in your body based on something that is given to you, as opposed to antibodies, which are the direct treatment for whatever protein we're trying to target. There are multiple ways of attacking alpha-synuclein. So throughout this talk, I'm going to try to highlight some of the more advanced medications that we have. Within each class, there are multiple agents that could be talked about. I'm going to try to focus on the ones that I think are closer to fruition and have the most research behind it. But this is by no means an exhaustive list. So for alpha-synuclein antibodies, there's a medication called prasinezumab, or PRX002, which is an antibody directed exactly against the misfolded protein in Parkinson's. It tries to leave alone the normal protein and tries to attack just the abnormally folded protein. And this has actually been looked at for the last several years, and the early studies were relatively successful. So there was a couple of larger phase 2 studies that were done. Now, some of the data was a little bit mixed. So initially, when they reported the results from some of these trials, they actually did not show any benefit for Parkinson's, which was actually very discouraging at the time. But when they looked at it deeper and in subgroups of patients, there was actually much more benefit than they thought initially. And that's been shown in a couple of trials since then as well, where they've shown that patients that took prasinezumab as opposed to a sugar pill had a 25 to 35% improvement in their symptoms. So this is one study that was done that was called the Pasadena study. And this is on patients with very mild Parkinson's, not on any treatment. And so these patients, without the quote unquote classic treatment of Parkinson's, without levodopa, still did significantly better than those that took sugar pills. It also showed that it delayed the onset of complications from Parkinson's. So patients that took this agent early did better than those that waited to take this agent. And the other thing that they found is that those patients that progressed quicker in general did better, which is another an indication that this is potentially a disease modifying therapy. That if we can get this into patients day one, then maybe it'll prevent the spread or progression of Parkinson's. Then they followed this up with a more recent phase 2 trial that was published just last month on those patients who are on medication, so a little bit more advanced in terms of Parkinson's. And once again, the initial data was discouraging. It didn't show any benefit. But when they looked at it in more detail, they kind of subdivided it. They actually did show that there was a lot of improvement in a lot of Parkinson's symptoms in a large group of individuals. So it was very encouraging to see. We're waiting on further trials from this agent and similar ones. But this to me is one of the more promising drugs and therapies that's coming out, just because of the data that it has, the fact that it's actually targeting the underlying problem in Parkinson's as opposed to just masking the symptoms. Well, if we can treat patients with something like this in addition to dopamine therapies, we can not only help the actual symptoms, but potentially prevent the progression or onset of worsening symptoms. And this is much closer to actually coming out than you can think, because it's, once you get to phase 2 trials, usually just a small phase 3 trial and it can potentially be approved. So hopefully for the next couple of years, we'll hear more about this agent. Something a little bit different, but in a similar realm, are the alpha-synuclein vaccines. So the way that the vaccines really work is we introduce a little bit of an abnormal protein into your body, and your body then produces its own antibodies to the alpha-synuclein. So it's basically teaching your body to attack the abnormalities in Parkinson's. Now, these are less far along, so I won't spend too much time talking about it, but there are two companies and two agents really being looked at in terms of the alpha-synuclein vaccines. They're pretty early on, so I don't have too much data to report, but the early studies were encouraging, they were safe. They couldn't tell effectiveness yet just because they were too early on, but it's still encouraging that they're looking at this as an avenue. And this could potentially be something where you get the vaccine once a year, producing antibodies that will kind of do the same thing as the antibodies in the previous drug.
Dr. Meytin, what's the difference between that one and the first one?
So the first one is an antibody. So we're giving you the material that's targeting the alpha-synuclein, versus the vaccine is giving your body the ability to generate its own antibody. So theoretically, that's a better way of doing it. It's the way that the flu vaccine, the COVID vaccine works. It sets your body up to do its own work rather than needing constant infusions of these antibodies. So the end result is the same, that we're attacking this alpha-synuclein. The way that we're teaching our body to do it is very different. Sorry. So another agent, which some of you may be aware of and maybe even participated in some of the trials for this drug, is another alpha-synuclein agent. It's not a vaccine. It's not an antibody. It's what's called an anti-neurotoxin. So it's a classification all of its own. And this is actually being looked at for both Parkinson's and Alzheimer's, because they're looking at this agent to reduce any kind of toxic inflammation in the brain that causes neurodegenerative disorders. And although there's not necessarily a direct link between Alzheimer's and Parkinson's, it's very common that patients can get both, just because both happen as we get a little bit older in our lives. So having an agent that could potentially treat or prevent the onset of dementia in addition to Parkinson's is actually extremely fantastic that we have this. And so there was a phase 3 trial that was completed. We are waiting on the final results from this study, but the initial results were very promising. There's almost 450 patients between the ages of 40 and 85 who received this agent. It was safe. It was well tolerated, which is one of the most important things we look at for a lot of these drugs. Is we want to make sure that they're safe enough to give. But more importantly, it also improved the physical symptoms of those with Parkinson's. And these are individuals with mild to moderate Parkinson's disease. And not only did their physical symptoms improve, but just as important, and probably maybe even more important, is that the cognition improved. And so, like I said, it's being looked at for both Alzheimer's and Parkinson's, but there maybe is more to it in terms of Parkinson's disease dementia as well. That because most of the other agents that we have only target the physical symptoms of Parkinson's. This agent could potentially target the physical and the cognitive symptoms of Parkinson's. So like I said, we're still waiting on the final results from this study, but the initial information that the company released was extremely promising and could theoretically be on the market sooner than later, since it was a phase 3 study. All right, so shifting gears just a little bit, I know I have somewhat limited time. So moving away from alpha-synuclein agents, I'm going to briefly just talk about genetic Parkinson's. So genetics in Parkinson's are relatively complicated. There are a lot of genes that increase your risk of having Parkinson's. The problem with a lot of these genes is they have a low penetrance. And what that really means is you can actually have the abnormal gene for Parkinson's and still not get the condition. And so the penetrance for a lot of the genes of Parkinson's are really only about 10 or 15%. meaning that there are a lot of people walking around with the genetic abnormality that increases the risk of Parkinson's, well, they'll never actually get Parkinson's. So it becomes a little bit complicated as far as who do we actually test for the genetics of Parkinson's, because most people won't actually get Parkinson's. So we generally don't test kids of people with Parkinson's just because they're still unlikely to get it in the long run. But for those that definitely have a genetic component to their Parkinson's, there are several agents being looked at specifically for that subset of individuals, because we do know that genetic Parkinson's is a little bit different than non-genetic Parkinson's in terms of the profile that we tend to see. So GBA Parkinson's is one relatively common form. So GBA mutations cause Gaucher's disease. So somebody may be familiar with the childhood disorder, Gaucher's disease. So if you have two genetic abnormalities for the GBA gene, as a kid, you get Gaucher's. If you only have one, you're at increased risk of getting Parkinson's down the line. And so there are two agents being looked at specifically for GBA and Parkinson's very early on in their research. Genetic treatments are generally much more complex than non-genetic treatments. Getting the gene replacement into the location where it's supposed to go is complicated. So there aren't a lot of studies looking at this yet, but for the small subset of individuals who do have a GBA mutation, this theoretically could be curative because they're replacing the abnormal gene that's contributing to that condition. And then just briefly, I don't know if anybody's from the UK or grew up in the UK. There's a medication called Ambroxol, which has been around now for ages. It's not approved in the United States, and there are various reasons for that, but it's an over-the-counter cough medication that has been shown to actually improve the symptoms in individuals with GBA Parkinson's, and even those individuals who may not even have the GBA mutation. The problem is in the studies where they looked at it, the doses that they used were massive compared to those that are just readily available. So I'm not telling patients to go run to the UK and stock up on the cough suppressant and start taking it. More research needs to be done, but the fact that this is an over-the-counter medication is fantastic, and this could lead to a lot of potential research down the line. The next gene that we sometimes see in Parkinson's is called the LRRK2 gene. So this is a gene that produces a protein that's involved in inflammation and also alpha-synuclein production. And so with this gene, they're actually looking at it not just individuals who have the mutation, but those who don't. Because if we can boost this agent, maybe those even without the genetic mutation will have benefit. And so the phase 1 studies were successful, but they're small and they're not really geared towards looking at benefit. They're looking at safety. But there's a very large phase 2 study that's underway. It's called the LUMA study, which is recruiting patients with and without the LRRK2 gene. Just because, like I said, a lot of the research for the LRRK2 gene has shown benefit even in those individuals who don't actually have the abnormal gene. All right, so I'm going to move on a little bit quicker just for the sake of time. So this is a medication that's actually approved. It's around, it got approved about a month or two ago, I think October of 2024. Although it's been around in Japan, Europe, and in Canada for about a year now. So this is an under the skin infusion of levodopa. So, and I'm sure you have heard in some of these talks today that, you know, inherently one of the biggest problems of levodopa is you have to take it by mouth multiple times a day. As your time with Parkinson progresses, the medication stops working as long. You have to take it more and more frequently, and then there's all side effects to it. Whereas pre-Parkinson's, the dopamine that's released in your brain is small amounts throughout the entire day. It's not these boluses of medications 6 times a day. So this is an under the skin infusion. So you have to wear it all day long. And the medication gets infused under the skin, this little cartridge, 24 hours a day. So you sleep with it, you exercise with it, you go to movies with it. And so instead of taking pills by mouth, it gets infused under the skin. So like I said, the data for this has been very successful. It's taken a very, very long time to get to this step. We've been looking for this now for honestly for decades to see if we can bypass needing to take medications. Finally got approved. And then there's another agent that will hopefully be approved soon as well that has the similar mechanism and similar concept to the Violev called Neuroderm, which we were part of some of those clinical trials and they were very successful as well. So hopefully there'll be non-oral options for patients to take levodopa. So this I just thought I'd mention, it's a relatively interesting delivery system. It's basically like a mouth guard that you wear that drops levodopa kind of in the back of the throat. So you have to take pills. There's not much data for this. I kind of stumbled upon this. I don't know too much about it, honestly, but it seemed very intriguing. So I thought I'll just bring up and mention it. But it's this little device that, like I said, just puts levodopa in the back of your throat, as opposed to having to take pills constantly throughout the day. Another one is essentially a dopamine infusion directly into the brain. So a lot of patients always ask me, if we know we need dopamine, why not just give it to the brain? That's a lot more complicated than you might imagine. And so we've tried to do this for many, many years. Even in the 80s and 90s, there were some studies that were doing this. The problem is safety. You have to get it safe into the brain, and you have to get it where it's supposed to go. And it has to be continuous to some extent, or find a way to have the brain release its own dopamine through this device. So they developed a different form of dopamine called anaerobic dopamine, which they found that they could infuse more safe into the brain. And so this is infused with this abdominal pump that then goes with a catheter up to your brain and infuses directly into your brain. So it's pretty invasive. But theoretically, it bypasses all the problems that we have with having to take oral levodopa. This is still very early on, very small studies. It's hard to get people to agree to these kind of studies, as you can imagine, because it's so invasive. So, the phase 2 study only had 9 patients. So it's not going to be approved by such small numbers, but the data behind the research really shows that it's possible. Now we got to just encourage people to join the studies to get some more data for this. The next group of drugs is something that a lot of people are actually very familiar with. So many people are aware of Ozempic, Wegovy. This has been all over the news. It was initially a diabetic agent, but really used more commonly for weight loss. But lo and behold, it actually has a lot of benefit in terms of neurology. And so there were several phase 2 and phase 3 trials looking at these agents for both Parkinson's and Alzheimer's. And it's the same drugs that are readily available already. And they were actually extraordinarily beneficial. And we think it's because it reduces some of the inflammation in the brain. It reduces some of the oxidative stress in the brain. And it might actually improve alpha-synuclein and these other abnormal proteins that we have. And so there are phase 2 and phase 3 trials for some of these agents that showed it's a significant benefit in terms of Parkinson's symptoms. The biggest problem that we find with these drugs in the Parkinson's community is that people with Parkinson's already have nausea, constipation, weight loss. That's what these drugs do. So we have to be able to balance the side effects of some of these agents with the benefits of it. Now, because it's not technically FDA approved for Parkinson's yet, we don't prescribe it for that. But if you are diabetic or trying to lose weight and you do have Parkinson's, this may be a class of drugs that may be something that you could go after because it's available. You have other indications for it. And although we're not primarily using it for Parkinson's, if they could help your Parkinson's or cognition, I think it's potentially worthwhile. So the next couple of drugs are kind of in their class of their own. They have very unique mechanisms. Some of them have completely unique mechanisms. Some of them are just manipulation of what we have available, but they're things that are not on the market whatsoever. So this is a drug that I'm actually very excited about. It's a specific antagonist of the dopamine 3 receptors. The reason why this is exciting is because it's targeting dyskinesia. So for those that aren't aware, dyskinesia is the excessive involuntary movement that tends to happen later on in Parkinson's, oftentimes from either too much medication in your system at any given time or just having advanced Parkinson's. The problem with dyskinesia is it's very hard to treat. As it stands, the only approved medication we have for dyskinesia is Gocovri, which comes with some side effects. And so it's not always the easiest medication to use. The only other alternative medication-wise to improve dyskinesia is to reduce your Parkinson's medications. The problem is we need them for a reason, right? So now we're reducing the medications that are helping tremor and balance to improve another symptom. Outside of that, it's deep brain stimulation as the treatment for dyskinesia. So this drug will potentially give us another oral agent to specifically treat dyskinesia. And so the phase 2 study that was completed not too long ago was successful in improving dyskinesia without worsening their Parkinson's symptoms. And so now they're enrolling a phase 3 trial to see if in a larger subset of patients, will there still be this same potential improvement. Another agent is an agent that's looking at dopamine agonism. So some of you may be on or have been on dopamine agonists, which are medications like Ropinirole or Nupro or Mirapex or Requip. These are what's called dopamine agonists. So these are drugs that kind of look like dopamine and go after the same receptors as dopamine. However, these drugs come with a lot of nasty side effects. And so a lot of us are moving away from using these agents because of their side effects. They can cause hallucinations, compulsions, sudden sleep attacks. And although it's rarer to have those, they can have them. So we always have to be vigilant with these agents, especially as the Parkinson's progresses. But some of them do work very well. So if we can find an agent that has the same benefit and a similar mechanism, but without the same side effects, a lot of these are once-a-day drugs would be very effective. And so this drug has gone through multiple different trials already, including phase 3 trials as an individual drug by itself, as well as adding this agent on to your current regimen, whether it's levodopa or something similar. And they have significantly improved the Parkinson's symptoms without some of the nasty side effects we generally see with dopamine agonists. And like I said, this would be a once-a-day medication. So if we can boost your levodopa once a day without some of the side effects that we typically see, that'll potentially save the need for surgery. Another one, which I'll briefly mention, and some of you may already be on this agent. Some of you may be on Rytary, which is a very popular formulation of levodopa. So Rytary is this capsule with these beads of levodopa that's kind of released slowly. So it produces a longer on time. Crexant is the newer form of it, and theoretically could be as little as twice a day dosing of this medication. I haven't found that much success in doing it twice a day, but it does certainly last longer than regular levodopa. So it's an option for patients that are taking the medication, 4, 5, 6, 7 times a day. Instead, you can take something like Crexant or even Rytary, which is 2, 3, maybe 4 times a day. Another agent is in a completely different class of anti-inflammatory drugs. And we do know that in Parkinson's, inflammation plays a role. We don't know to what extent. We don't know if it's the chicken or the egg, but we do know that there is inflammation as a role in Parkinson's. And so there's a whole slew of research looking at inflammation in Parkinson's. And so this is one of those drugs that has gone pretty far along. And so in the phase 2 trial with this drug, in those patients that took this agent in addition to their levodopa, they did significantly better. But not only that, they improved their non-motor symptoms. And so that's been one of the challenges with a lot of Parkinson's drugs is, first of all, they only really help the physical symptoms of Parkinson's. Number two is they oftentimes worsen the non-physical symptoms. So levodopa is well known to drop blood pressure, to cause fatigue, to cause hallucinations. So we're always looking for ways of improving symptoms without those dopaminergic side effects. And so this would potentially be one of those options because it's improving the physical symptoms, but did not worsen the non-motor symptoms and in fact improved them, particularly fatigue and restlessness, which are very common Parkinson's findings, got better with this drug. So once again, this is a non-dopamine way of improving Parkinson's symptoms. Another one is once again a completely separate class of medications, looking at what's called G protein coupled receptors in the brain. And so the idea here is to kind of lower the activity in parts of the brain that are overactive or misfiring in Parkinson's disease. So this is a group of medications that really hasn't gotten much highlight yet, but I think it's advancing rapidly. And we can see a lot more drugs and research with this class of medications. And so the phase 2 study, which was a relatively large study, it was almost 150 patients that specifically were more advanced. They had 2+ hours of off time, meaning that they were taking their medication throughout the day, but they had at least 2 hours where the medications didn't work well enough. And so when they added this drug to levodopa, patients got 1.5 hours improvement. So they almost closed that entire gap of off time. And once again, without causing any decline in the non-physical symptoms, and also actually improved them again. So this is another one of those drugs that not only doesn't worsen the non-motor symptoms, but improves sleepiness and sedation. So it's another potential add-on to levodopa to improve that on time without the concern that we're going to make things worse. And that's one of the toughest challenges as Parkinson's progresses is how do we improve the symptoms that are still there without worsening the other symptoms. And so drugs like this could potentially allow us to do that. And then very briefly, because patients always ask about stem cell therapy, and this is really a talk on its own. Stem cells are extraordinarily complicated. It's a lot more complex than people understand. There are a lot of companies out there that will claim to give you stem cells that are not really the true stem cells that you need. Most of these companies are not approved agents and they are not covered by insurance. So I personally do not recommend any of those companies because we're very far away from truly understanding how to use stem cells in Parkinson's disease. But this is one agent that looks promising and safe. But the data was a little bit mixed. So although it was relatively safe, it had some complications from it because of the procedure itself to get the stem cells where they need to go. So if you give somebody stem cells through the blood, you're hoping they get to their final destination. They're not going to really get there that way. And if you implant them directly into the brain, you're opening yourself up to potential risks of pretty invasive brain surgery. So there's a lot of things that we have to look at for stem cell before even really considering this as a potential treatment. But theoretically, if we could find this would be the quote unquote cure of Parkinson's. If we can replace the dopamine cells that are not working well, theoretically, you wouldn't have Parkinson's anymore. Now, obviously, that's a big overstatement, but that would be the kind of the holy grail and the goal of these kind of medications. So that's pretty much all I had. I know it's kind of a very brief overview just because of the time I had. But my hope is that the paradigm of treating Parkinson will change from you're diagnosed with Parkinson's, here's levodopa, see in a few months, to here are the 20 different options we have based on your individual symptoms, and how do we get you better results. So that's all I had. Like I said, I know it's a lot of information, and I don't expect anyone to memorize any of this. Just want to show what
Thank you, Dr. Meytin.
Before we ask any questions, I would like to welcome and we invite you to get dessert and coffee, and then we can come back and ask questions, and then we'll go to our breakout session.
I think maybe not questions.
Maybe not questions.
I'm here for questions. if you need them.
Yes, you can come up to Dr. Mayton directly for any specific questions.
Wait, do you want to announce the breakout?
Oh, yeah. While you're getting your dessert, let me announce the breakout session happening at 2:00. Dr. Salvadori is here in the main floor, right here.
It's
Speaking about Parkinson's and pain management. Dr. Rocky will be in the family consultation room, which you can follow me to go to the family consultation room, talking about adjunctive therapies for Parkinson's treatment. Amy will be on the executive floor, which is the third level. Go to the elevator. She's talking